Good morning, good evening, everyone. Wherever in the world you're joining from, Happy New Year. Welcome to 2026. And like we were just joking that what a great topic to start 2026 on, to become pain-free. Let's make 2026 the year that we live as pain-free as possible, both physically and mentally. So I would like to just quickly go through some of the housekeeping stuff, and then we can get into the conversation with Dr. Kashinath Banga. As always, please type your questions in the chat window, and we'll make sure to answer them at the end of the session. And I would appreciate if you could stay on mute so that it's clear for everyone else. Most of you are already on the Longevity Lab community, but if you're not, lots of good reasons to join it. It's free, and amazing, interesting speakers like today's have been on the session, and you get to ask your questions which are answered by real doctors. Joining it is easy, and our speaker for next week is going to be Dr. Jahnavi Melankari, and the topic I thought was very interesting, and that's why I requested her to have this session. She is a psychologist, a child psychologist, and the topic that we will cover next week is, as the world becomes more where mobile is so, such an integral part of our lives. How do we bring up our kids in this world? We had the opportunity to spend the first 10, 20, 30 years without a mobile device. But today kids are born with it. And what is it doing to them, and what can we do? That is practical. Saying don't ever give it to them is not going to work. But what are practical tips? And I think for those of you who have kids, grandkids, nephews, nieces, I think this will be a very, very good session for you to attend. All right, over to our topic for today. With our conversation with Dr. Kashinath Banga, I'm going to leave his introduction up on the screen. This is a shortened version of all the amazing work he's done, but I want to provide a more personal introduction. As we get older, pain just seems to become an integral part of our lives, although it shouldn't be that way. But we almost accept it. Hey, you're getting older, of course you're going to have aches and pains. And I have seen from my own experience personally that the pain I used to feel after playing a game over a weekend used to be reasonable amount, and I just thought that was something that was going to be a part of my life. But then as I got introduced to strength training and various other aspects, both lifestyle and in some cases pharmacological, it definitely helped. And today I can say that the amount of pain in my life is very, very much less than what it used to be earlier, which is almost counterintuitive. But the reason I'm especially excited about having Dr. Banga on this session is because I saw what he did for my mother as she was going through her last few months dealing with cancer. And while it was clear to us that nothing could have been done about the cancer itself, the pain that came with it was just overwhelming. And it's very hard to see your loved ones suffer, and you can do nothing about it. And I did not know of the existence of a specialty called pain management. I mean, Dr. Kashinath Banga is a very, very reputed doctor, but his expertise that he has chosen is pain management. And I wish I knew this earlier through my mom's experience. But I'm glad I got to know at least when I did, because the pain of cancer did not go away, but the pain, the physical pain that came with it was dramatically reduced because of Dr. Kashinath Banga's efforts. And now, as my father is going through his battle, it's especially valuable for resources like Dr. Banga to be around, because it dramatically has improved his pain. He's in a lot of pain, but whatever can be done is a bonus. And so for those reasons, I'm very grateful to have him as a guest on our show today. And so, without further ado, Kashinath, welcome to the community podcast.
Thank you, Nikhil, and thank you for such a wonderful introduction. And I am really grateful to you that you honored me, and asked me to come to this wonderful podcast and this part of this wonderful community. I
Thank
really
you.
thanks to you.
Thank you, Kashinath. So, let's get into it. Let's start with just pain, right? We keep talking about pain. But there are two very different types of pain: acute pain that you feel right there and then, and chronic pain that just goes on and on and on, and we just live with it and we suffer with it. Can you talk? I mean, this is a very high level thought I have, but you live it and you understand it. What is the difference between acute pain and chronic pain, and why does the body sometimes just keep hurting long after an injury has healed?
Right. So basically, duration-wise, there are two types of pain. One is acute, as you correctly mentioned. Second is chronic pain. Any pain which is of less than 30 days duration is acute pain. Any pain which is more than 1 month to 3 months is considered as a chronic pain. This is one definition. And as you correctly mentioned, if suppose there is some injury or if there is something going inside the body which is very obvious, then it manifests as an acute pain in the body, in that part of the body. Whereas chronic pain is even sometime there is no any radiological or no any other disease, or the pathology has been cured and still the patient is suffering from the pain. That is a chronic pain. The classical example I can give right now is herpes zoster, shingles pain. If there is a shingles in some part of the area, acute pain is there when that rash erupts. But in some patients, even after the treatment, even after the disease is being cured, the pain continues for 1 month, 6 months, 2 years. This is one pain. And what happens is there are different pathologies for it, or different reasons for this. One is the every single part of the body can cause a pain. That means skin can cause pain, the bone can cause pain, the nerve injuries, the nerves can cause a pain, can be responsible for the pain, the muscle can be responsible for the pain. Every single organ can be responsible for the pain. Now, what happens is, so if there is a nerve injury and some chronic changes occurs into that nerves, and then nerve starts firing even if it has been the primary pathology has been healed or the primary disease has been healed. This is called as a neuropathic pain. One. Second, what happens is still the science is in evolving phase. So we see a lot of patients with let's say a back pain or spondylosis. Now what happens is, you do the MRI of the patients. By and large, there are four categories of the patients. The patients who take acute pain, take painkillers, conservative management, they do better. Or there are some patients where the surgery is needed. Severe some spine challenges there. Now there are two more groups of the patients. They are not responding to the painkillers or conservative management, and surgery is not needed. So when we do an MRI, there is nothing big as of now. But still the patient has pain. That simply means some part of the body is paining, where as a science we are still not able to make a perfect diagnosis on the basis of radiology or blood investigations. Yeah. And there we had some another technique called as diagnostic injections. So small changes, even if any small change, which probably is not that evident on the radiological report or blood report, can cause a pain. And so this is a basic difference. Acute pain is the pathology is very obvious. Duration is of short duration. Chronic pain, sometimes pathology may not be obvious. Sometimes the primary disease might have been cured. Still the patient has a pain. So these are the basic two differences between the acute pain and chronic pain.
So, it's very interesting because what one of the key takeaways for me from what you just said is that very often when it's easy to point to something in a report, then everybody understands how that works. But
Right.
so often we feel pain We go with the report to the doctor. The doctor says there's nothing, no issue. I don't see. Maybe it's in your head, right? But what I took away from what you just said is it may just be a case that medicine has not progressed far enough that the report is being able to capture the source of the pain, right? And that is so reassuring to hear, not because the fact that medicine has not progressed, that there is still room for that, but the fact that if we feel the pain, and even if it does not show up in a report, doesn't mean you're not justified in feeling the pain, right? Because very often we are told, no, 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 it's in your head. Go home, take an Advil, you'll be okay. But maybe there is something deeper that we have not understood.
So you pinched the correct point. The pain is in the head, and we are listening these things since we were listening this since when we were in the medical schools. I will tell you the simple mechanism why this happened. Have you seen the same types of the patients undergoing the same surgery, but having a different pain experiences?
Mhm.
Does this happen? For example, same age group of the patient undergoes same surgery, but some person has a good pain tolerance, somebody does not have a good pain tolerance, right? This we have seen. And there are some patients, in spite of giving everything, the still pain persists. This is one category. So what happens is the God has created such a beautiful body. I will just explain in some time. See, suppose there is some pain here. See, suppose I have some pathology at the finger tip. Now, how my body or my brain recognizes the pain is from the peripheral receptors. Pain via nerves goes into the spine, and from spine it goes to the brain, where the brain comes to know that okay, this person has pain at the tip of the finger.
Hmm.
Now, suppose we have some impact over there, and this will answer most of the questions. For example, I have a X injury here, and let's say, just for the purpose of discussion, I should have the pain of 100
Hmm.
units, right? So I have X injury, which should give a pain of 100 unit, right? Ideally, my brain should capture it as an 100 unit pain, right? But this doesn't happen. What happens is there is something called as pain modulation system. The system in the body which modulates the pain. And what is that system is, see, there are peripheral shock absorber. So I'll talk in general, I'll not
Mhm.
talk in a very scientific, I'll try to explain it in our own
Okay.
language. So there is peripheral shock absorbing mechanisms. Say out of 100, see 25 units get absorbed peripherally. Now my spine will reach, will receive the 75 units, correct?
Mhm.
My spine, again, there is some shock absorbing mechanism. So 25 units get absorbed there. My brain will receive 50 units. Though I have a impact of 100 units of pain, my brain will receive as 50 units.
Hmm.
Now what happens is, let's say this impact continues. This impact continues. Say, for example, this injury is not getting healed, or there are some challenges. So it's going on, it's going on, going on. Now, when I say the spine has mechanism to modulate, that means there is one depressive system. There is one system which depresses the pain, which has an chemical mediators, which decreases the pain, which depresses the pain. Now, what happens over a period of time? My peripheral shock absorbing mechanism gets fatigue.
Hmm.
Now I have impact of 100. Initially, 25 was, getting absorbed peripherally, but it will not get absorbed. My spine now receives 75, right?
Yeah.
My spine will receive 100 out of 100 because 25 will not get
Hmm.
absorbed. And spine will modulate 25, my brain will receive 75. So case scenario one, 100 impact, brain was receiving 50. Now 100 impact, brain is receiving 75. The pain continues for next few days or few weeks. Now even my spinal level modulation get absorbed.
Hmm.
Now impact of 100, my brain is receiving directly 100. 25 periphery, 25 at the spinal level, they are not getting modulated. From here, one interesting phenomena starts. After some time, what happens is, I have impact of 100. Now there is something called as excitatory mechanisms that comes into the picture.
Hmm.
So excitatory mechanisms means impact of 100 and my periphery receptors adding 50 to 25 to it. So my spine will receive 125. Spine will add again 25 to it, because there cannot be vacuum. If somebody is getting repressed, it has to be replaced by something. If the depressive system, the pain depressing system is affected, it will be get replaced by the pain exciting system, excitatory system. So I have impact of 100, my brain will receive 150 units. Now what happens, over a period of time, my injury heals. I don't have any impact of 100, but still 25 excitatory neurons of the periphery, 25 excitatory neurons of the spine are sending the signals. My brain still receives 50, and that is the reason of the chronic pain. In spite, the primary pathology has been cured.
Wow. So there are
Now,
two. Yeah. Can I just make a point just to make sure that we're all following along? Because I think you explained it really beautifully.
yeah,
There are two things I've caught so far, Kashinath. One is that when you have pain for a long period of time, that modulation that was taking uh, uh, place to reduce it in the brain is going away. So the pain actual impact might have been the same on your finger, but your brain over time is getting all the initial parts are getting fatigued. So the brain feels more and more pain for the same amount of input. Right? So that's
yes,
one thing you spoke about. And then the second thing you spoke about is, even if that pain goes away, the source of the pain goes away, because of the excitatory systems, you will feel it as pain for long after the source of pain has gone away. They're two very different but important elements.
yeah. And third element is, as I said, there is a pain suppressing mechanism. Now, the interesting part is the modulation, the chemical neurotransmitters there are the same, which keeps our good mood. Now, if they get depleted, what will happen is naturally our mood will go down, will go into the depression. And that is the reason the patients with chronic pain can have a depression, or the patient who is suffering from the depression can have a chronic pain. And if the patient has a chronic pain, patient has a depression, and if all reports are normal, and if somebody says your pain is in the head, the depression will increase. The fact is, it's not like that. The patient has a pain. We just need to understand what is causing the pain and how can we address.
Understood. That explains a lot. Uh, a slight digression, but hearing you talk about this makes me one think. You are a doctor, you graduated from a great college. At what point did you decide, I want my specialization to be pain management? Like, that's what you've dedicated your medical career to. Was there something that happened, some incident that got you into this? Because this is such an unusual specialty to have.
Right. So yes, I had a personal experience. My mother had cancer breast, and her cancer was spread to the bones, and it troubles a lot. And at that time, we were doing almost everything under the roof to decrease the pain. And ultimately, I went to Dr. Nankar. He's also pain specialist from the Pune. He put the epidural, and somehow in cancer, it's not it's not possible to bring down pain to zero, but we brought it down to the manageable level. And that day, it struck to me that, okay, this is something where we should work a lot of scope in the sense of the innovations. And a lot of people, the world needs it. Almost everybody needs it. So that was one incident which changed my mind. And then I went to find out what are the different courses. And then we became the full-time pain management specialist.
Yeah, I mean, it's an unfortunate reason, but
Yes.
it's a fortunate outcome, because, like I said earlier, a lot of us are benefiting because of experts like you who have taken this up as a specialty. So, carrying on what you said, uh, when you look at people, I mean, I found, when we are in our 20s and 30s, we don't feel too much pain. We can deal with it. I guess now I understand why, because those receptors are still taking care of buffering a lot of that pain. But once we are into our 40s, 50s, 60s, 70s, and so on, what are the common pain conditions that you see? And then we'll talk about, are there things one can do to prevent them? If they're coming from lifestyle, can lifestyle also be changed to deal with it? But let's start with, what are the most common pain conditions you see in your
Yeah.
clinic?
Yeah. So now I'll divide it age-wise. Approximately in adolescent age group or early young age group, we are seeing a headache, a tension type of headache, and migraine is really on the high. So this is one condition where it is like almost like an stress induced, a different kind of, either it's physical stress or it is a psychological stress due to various conditions. This is one thing. Second thing, in the IT professionals and the young generation, when I'm saying this, the neck pain, the chronic neck pain, spine related, is on the it is like an epidemic. Because what happens is, now, ideally, a neck is angulated anteriorly. Though you can see the neck is this, the angle is anteriorly. Yeah. So this is the angle of the spine inside me. And now, due to the laptop and due to the mobile, not only we have to make it straight, but we are exactly doing the opposite what it should not be.
Right.
And trust me, Nikhil, it is the one condition where the neck pain, one-sided neck pain, the headache from the posteriorly, that is called as cervicogenic, and the spine related issues are really on the very high. Because either this is in profession, or now I'm very fortunate, you brought that subject, that the next speaker is going to talk on the mobile addiction. The moment we saw the peoples who are, they spend hours together onto the phone, that means for hours together, the neck is flexed. Usually the head weight of the head increases by 5 kg for every 10-degree increasing the angle of the neck, and so much of the load spine carries for so long period of time. So young patients, this is on the very high. Middle age to little 30s, 40s, 50s, due to the lifestyle, the spine related issues and the knee related issues are on the very high.
Hmm.
One thing is very, again, very strikingly nowadays increasing is cancer related pain, because as the patients are increasing, the cancer related pain is there, and it is considered as one of the worst pain and one of the most difficult pain to treat, because no, we cannot point out a single thing where either we can use or that can be treated. But yes, we are in very much position to make the patient at least comfortable. So this is one thing. And
Can I ask you a question on that?
yes, yes, yes.
In cancer pain, the reason that it's hard, even though someone might have, let's say, prostate cancer or lung cancer,
Huh.
the pain could be in any part of the body. It's not just the source of the cancer, right? That's
Right.
why it becomes hard to treat it.
Right, right. So what happens is, so in cancer, the sources are, there are different sources. Say for example, say for example, if it is prostate and if it goes to the bones, like the vertebrae and the different bones, and if it is a spreading. Now, if we treat one part and the spread is to the next part, that becomes challenging. This is one thing. The side effects of the radiation, the side effects of the chemotherapy, the radiation induce inflammation of the different areas, or the chemo induce nerve affection can lead to the pain. So what happens is, usually this pain is multimodal. Multimodal means all the different angles. As I say, every single thing in the body has capacity to cause the pain. See, if I have injury at the fingertip or something, this is the only part which is a pain generator. But in the cancer, it is the skin, it is the bone, it is the disc, it is the nerves, it is the inflammation. All these are the pain generators, and that's why sometimes it is not sometime, but to be very honest, 0 by 10 pain is difficult. But yes, now the science is such that with a multimodal, like with given the blocks, sometime doing some surgeries with radiation, with opioids, with different drugs, we can bring down to less than 4 by 10. So 4 by 10, this is a World Health Organization accepted standard. The WHO accepted the standard that the pain in cancer patients should be less than 4 by 10.
Okay, so just to clarify, so if your pain is 10, means you are in immense pain.
Immense.
So you're saying that what the WHO has said is the pain treatment, if you can bring it down to 4, you are it's good,
It's good.
right?
It's good.
If you're
In
still
cancer
at 6
patients.
and 7, there is room to bring it down. Whereas for acute pain, you just broke your finger or something like that, you could potentially give enough to bring it down to 0. But for cancer, 4 is more realistic.
Yeah, that is realistic. That's true. That's true. And that's why I said, still there is the scope of science has a lot of scope to bring down it from 4 to 0.
Yeah. And the other point you made, because you use the word multimodal in 2 different contexts, if I understood correctly. One context you use multimodal was pain generators can be multimodal. Your skin, your tissue, your bones. So that's one sense of multimodal. But then you also use multimodal in the context of the ways to address that pain. And we'll talk a lot more about that. The blocks, the chemotherapy, the radiation, and so on and so forth. So it's multiple sources of pain, multiple approaches to solving that pain. Is that the right understanding?
Yes, that's the right understanding, and that is true for especially for the cancer pain.
Yeah, got it. So moving on. You spoke about posture, right? I think especially the mobile posture has become such a big issue. How does, if someone has pain, how does exercising or our nutrition or sleep help? Because for example, one of the things I see very often is people now know that they need to do strength training, but they have had historic pain in their knees or lower back. Now, it's almost like, okay, now I cannot do strength training because all those things get impacted. How do you advise people on using lifestyle to combat some of the sources of pain?
Right. So this is actually a very wonderful question. The lifestyle modification is prevention, one of the most important factor for the prevention of the pain. Even it is the most important factor for the treatment of the pain, and it is again most important factor for the rehabilitation after the pain has been treated. So let's take an example of exercise and the spine. What happens is in the spine we had a disc in between 2 vertebrae. Now what happens is the disc has no blood supply. So it's sponge-like structure and there's no blood supply to it. So how does nutrition goes to the disc and the material which is unwanted taken away from the disc is by diffusion. So a sponge, if we press the sponge, inside material will go out, and when we remove the sponge, when the sponge will relax, the outside material it will absorb. That's called as diffusion, right? Now, how does it happen is the movements, body movements or exercise when the disc is in between 2 vertebrae. So if we do some body movements, there will be a compression and relaxation of the disc. When there is a compression and relaxation of the disc, there will be the energy supply, the nutrition supply, the oxygen supply will be there, and the debris will be taken out. And when this is possible is when we do any kind of exercises. Any kind of exercise is okay. Here, when I mean an exercise, neither over exercise is good, not under exercise is good. And it is different for a different individual. Say for some person, 5 kg is very high. For somebody, 50 kg is absolutely okay. It becomes gradually increasing the part of that training. But this is one way the exercise help. The second way exercise help is exercise increases the blood flow to all the parts of the body. And from there, the chemicals which causes the pains are washed away. This is second thing. Third thing is exercise. The morphine is considered as morphine and fentanyl. These are the considered as one of the uh, most potent analgesics available, and that is freely available in the body. So
Hmm.
endorphin is the chemical which is freely available in the body, and it is secreted when we do exercise, any kind of exercise. Like it could be a game, it could be a swimming, whatever you like. It is secreted when you do a meditation. It is secreted when we had a good thoughts, because ultimately there are good chemicals and bad chemicals, as I said. When you had a good thoughts, when you listen to the music, and this increases a lot of endorphins. So the exercise helps. It increases the secretion of endorphins, makes the increases the blood flow. So tissue repair is very good, and that decreases the pain. And we all should uh, you know uh, it is very easy, and at the same time it's very difficult. I say, if you do a regular, correct, proper exercise, there is no way that patient can have chronic pain. Or even if it happens, it's very easy to treat it. But say suppose some lifestyle is that I am now looking at the mobile continuously. I started the neck pain, we treated it with we'll talk it in later, with different modalities. After the treatment, now I go back to my own lifestyle of looking into the mobiles continuously. Pain is definitely going to come back. So this is how the exercise affects a lot. Nutrition, yes. Vitamin B12 and calcium, these are the nutritions. Unfortunately, what happens is our nutrition, if it is not good, then there is a deficiency of these vitamins, calciums, which again is important for the bone health. So that way, nutrition also has a very important and integral part of the body. Another thing is sunlight exposure. We always say, in Pune city, I start my day in the house in the morning, go back, go to the car, and then to the clinic, and then back to the office. Where is the sunlight exposure? And sunlight exposure has all the known and unknown. Lot of known is vitamin D is one of the important thing, and lot of unknown factors which are important, so that our bone strength, our muscle strength is nicely maintained. So everything is important, and we all should take care of this.
Yeah, yeah. And how about sleep, Kashinath?
Right.
Does Hmm.
So yes, sleep, again, good chemicals and bad chemicals. If we take a proper no sleep, there are two factors into the sleep. Position when we are sleeping. Now,
Hmm.
few people had an habit of taking two, three, four pillows of the sleeps. So their neck goes like this. There is a chance that the neck pain will start. Or if somebody is using, a very smooth or very hard surface, then there is a chance that some part of the body, why some part of the part of the body which is not properly aligned during the sleep, there is a chance that it can trouble, or it can cause a chronic pain. This is one thing. Second thing is healthy sleep. Means what? If somebody is sleeping properly for 6, 7, 8 hours, 9 hours, that helps in secreting all the good chemicals, which decreases the pain. Some of the endorphins are secreted. And if the sleep is not proper, or if sleep is not on time, then that will secrete the excitatory neurochemicals, and those will increase the existing pain, or those will not help in decreasing the pain in time. So sleep is also a very important part of the pain management.
Is there a position or for sleeping that you recommend, Kashinath? Uh,
Okay.
Side sleepers, back sleepers. Is there something that is better or worse?
See, the very I'll make this very simple. So not only to the sleep, but for anything, the simplest position is your head should be in the neutral position.
Hmm.
Yeah, because what happens is, if the head is not in the neutral position, that means if you take too much of the load, or if you decrease too much of the load, then the body's neutral position, if it is hampered, then that can cause the pain. Now, it could be different for different persons, but that is one thing.
And neutral position is where the thing is slightly at an the angulated backwards. Is that right?
But no, okay. So when we sit straight, inside the spine is already curved.
Okay.
Okay, it's not evident outside because outside the soft tissue is such that we don't see that it is like curd.
Mhm.
But the part which touches the surface, it should be at the same level. The occiput, this is called as occiput area, and the back of the area. This by and large should be at the same level.
Got it.
It
And
changes slightly with a different person. So plus minus two standard deviation is okay, but it should not be too much of the excessive flexion or excessive extension.
got it. Got it. And uh, side sleepers versus back sleepers. Does that change anything?
Okay. Uh, there are different schools of thought into this, and we get a different patients. So by evidence wise also, there are different schools of thought, and even we get a different patients. Like so, the what we came to the conclusion that any of, as I said, any of the excess abnormality in position should be avoided. So if somebody is sleeping normally, comfortably, and if he's okay with that, even that is okay. Or even if somebody is sleeping side at the one side, so okay, which we say laterally, the side sleepers, and they are taking proper pillow, even that is okay. But what happens is when you are sleeping onto the lateral side, there is a possibility that sometimes there is a compression of the lower part of the part which is downside, either the hand or the leg. There can be little compression, but that's okay. So the final conclusion, what we came to know is, if it is comfortable to you, that is absolutely okay. You
Yeah.
need not to change it suddenly from like how to go ahead about it like this.
Got it. Got it.
Yeah,
Use your own pain. If you're feeling pain
zero.
when you wake up in the morning, there's something
Yeah,
wrong about how you're sleeping.
yeah, correct.
Got it. But I think there were two very important points, at least I took away from what you said, Kashinath. One is that exercise releases endorphins, which are sort of the easy version of morphine, right? And that's a very powerful way to think about it, right? And the second thing, which I actually had never, and I thought I was very sort of aware of these things, but I was completely clueless about, was the fact that the discs don't get any blood supply, which means the only way for it to get in nutrition or get out all the junk is through exercise,
Yeah,
right? And so
correct.
jumping, stretching, running, all these things are all helping, get the discs the appropriate energy and cleaning up that it needs.
Right. So it is mainly outer small part, 1/3 or 20% parts, there is a blood supply, but inner part, there is no blood supply.
Right.
Yeah.
Right. Um, let's talk about the treatment approaches. You spoke about the multimodal ways. You mentioned the word blocks, and I'm sure there are other such terms. It will be useful for you to explain for the audience, Kashinath, what are these different approaches in pain management?
Yeah. So basically, when we talk about chronic any condition where we are talking about the chronic pain, the treatment, various options for the chronic pain. Naturally, the painkiller is not an option. Of course, here is one exception, and that exception, as we said, is a cancer pain. But for all other patients, the painkiller is not an option. How many days will I take the painkiller? And those ultimately will affect the different parts of the body. So the various treatment options ranges from the very simple things to the very advanced things. Like simple is the dry needling. So we just put a simple acupuncture needles into the trigger under the sonography. So we found that muscle, we put the needle into that trigger, and that helps in releasing that trigger. The next option is called as, if some nerve suppose some nerve is getting compressed. So what we do is we do something called as hydrodissection of the nerve. So we put some fluid, any of the fluid, putting around that nerve will create a space for that nerve. The moment pressure decreases, the pain goes down. So this is an hydrodissection of the nerve. Nowadays, we are doing the regenerative treatments. As I said, say for example, there are few injuries where the either tendon or muscle is partially tear. like shoulder, some partial tear is there in some tendon, or the some muscle is partially tears means it's not completely torn, but it's not normal. Either 25% or 50% there is an rupture of that either tendon or muscle, or knee if there is some meniscus injury or the ligaments injury, and if it is an partial tear or partial injuries, here we do a lot of regenerative therapies. Regenerative therapies means nowadays we are taking the blood and taking out the plasmas, the growth factors, or we take the bone marrow, we process it. Now the commercially available kits are also available into the market, but the what we prefer is patient's own blood or own plasma and own bone marrow. So we processed that, and under the guidance, image guidance means either under the ultrasound guidance or the CT scan guidance or the fluoroscopy guidance, what we do is we put that factors, either plasma or the bone marrow, into that torn part, and this is called as regenerative therapy. And it beautifully, it increases the strength of the muscles or the torn part of the, it heals completely that tendons. Even the early degenerative changes like early knee osteoarthritis, so age-related knee problems. In early changes, very successfully the regenerative therapies are giving the promising results. This is second. We use some medications, as I said, neuropathic medications, where those good chemicals we increase. So those are the medications where, rather than using the painkillers, we increase the strength of the inhibitory system, the system which inhibits the pain. So how we do is we give the medications which, will increase that good neurotransmitters. Then we had various blocks. Block is a misnomer. Now we call as minimal invasive interventions. So here we find out the culprit nerve which is giving the pain or which is a possible source of the pain. And what we do is we put a local anesthetic or a steroid injection over there. Even to the few nerves, we do something called as a radio frequency ablation or cryoablation. Radio frequency ablation means we hit that nerve to 42-degree temperature to 60 to 80-degree temperature, depending on which part of the nerve it is. So what happens is that painful nerve or that abnormal connection, I said, no, that excitatory neurons will fire abnormally. So we ablate that nerves. So this is called as a radio frequency ablation. And exactly opposite of that is a cryoablation, where we freeze load nerve. So with the using either CO2 or nitrogen, we'll go down and freeze them to minus 80-degree temperature. So abnormal nerves will stop their functioning. And now when we say stop their functioning, it is only an abnormal nerves, because the science is so involved that we have ways to find out whether this is normal, abnormal, or this is this an any important nerve which we are not damaging. So we had different techniques to come to that. Then coming to the next therapies, we had the spinal cord stimulator and intrathecal pumps. So in cancer patients, especially, this stands true. If the patient is not, is on the opioids, and if the opioids is not getting tolerated, we fit small pump into the skin, and then we deliver that drug into the spine, the CSF, which goes into the brain. So very low dose of the morphine goes continuously into the spine and this goes into the brain. That helps in decreasing the pain. And now this something is called as a spinal cord stimulator. So spinal cord stimulator is again a device where that small device, it is exact opposite of the pacemaker. So pacemaker will stimulate the heart, and spinal cord stimulator will inhibit the pain signals that we fit into the spine. Even though it appears very complicated, for the patient, it's just done through either minimal invasive or the small surgery. And now we have cool radio frequency ablations, like we do it for the spine, as I said, where the patients are not in the position, they don't need a surgery, but the pain is not going down. We do something called as radio frequency ablation, cool radio frequency ablation. It's especially has a wonderful results for the knees and the shoulders and the hip. Even few cases of the spine, the radio frequency ablation has a wonderful results. And there's something called as post-spine surgery or post-surgical pain. And for that, the botulinum toxin injections uh, and peripheral neurostimulations. These are the various, lots of the
Wow.
treatment options which we usually don't heard, or usually we are
Yeah.
not aware of. Yeah, yeah, yeah.
Yeah. I mean, of the list of things you just mentioned, Kashinath, I don't think I'd known more than three of them at the most. But
Yes,
there are
yes.
so many. So they all sound very technical. Are these difficult to administer to the
No.
common person?
Right. So yes, you are absolutely right. This sounds so many complicated. No, it's very simple. Almost 95% of the things are done through the needles.
Hmm.
It is the expertise is needed. The advancement of the science is needed. Like we have to do this either in the CT scan or ultrasound. But this is not difficult to administer. Even for the patient, it's very simple. It's like the needle. You go in, you perform the procedure, you take out the needle. The accuracy has to be there, and that's where the part of the skill comes. But the whatever the name suggests, very technical and very difficult. It's not difficult for the patient. It's just most of the treatments are just done through the needles, and those are either daycare or maximum 1 day admission is needed. That's it.
Yeah, I was going to ask you, like, is it like a, 2, 3 day process? Is it a 1 hour process? But I guess it sounds like it could be as short as an hour and it could be as long as a day
Yeah. Except for the spinal cord stimulator and intrathecal pumps, the stay is for 3, 4 days to 7 days.
for those two.
For those two. But for all other procedures, either few hours to maximum a day.
Got it. Got it. I mean, this is just so fascinating the way you're explaining all of this. So much new learning. Um, when do you decide, Kashinath, and I'm assuming there's no easy answer to this, but let me ask it in any case.
Yeah, yeah.
When do you decide someone needs surgical intervention versus one of these much more outpatient type interventions?
Right. So, for any pain, let's say for example the pain related to spine, some has the sciatica or disc bulge, or the distinction is very very clear. If something called as red flag is present, then he is a candidate for the surgery, and which is fortunately present in less than 5 to 3% of the patients. Like if there is an infection, if there is like an severe trauma or the fracture or the spreading cancer. Spreading cancer means newly diagnosed cancer, not oldly diagnosed cancer.
Hmm.
If there is some patient comes with the back pain and the first time he is diagnosed as cancer, then that part. Or some if there is a patient whose body part is not moving, this becomes a clear cut a surgical case. But as I said, the chances of this, the patients overall in the society are less than 5%. So this is very clear cut. And the second category is they are not responding to the routine medical treatment like physiotherapy or the various supplements or the painkillers for 2, 3 weeks. So these are the candidates where we intervene. In short, it's very simple for us. If somebody has a very, very severe kind of injury, he is a case for the surgery. Rest all are the patients where we can intervene.
Right. But I'll tell you, as you were saying this, one realization struck me, and I'm assuming some of the people on the in the audience might have a similar view, which is today, if I went to a surgeon and I said I have a problem, and this actually happened to me, right? I had a soccer injury. I went to the surgeon. The surgeon looked at it and said, "Yep, requires surgery. Let's do it as soon as tomorrow." I was like, "Hold on, I need to be mentally ready for this. And I can't believe that, yeah, it's paining a lot, but does it really need surgery?" So I said, okay, I need to think about it. I went back, met a different doctor who said, hey, why don't you try physiotherapy and some other pain management and see. And I did that. Where I said, worst case, I can always go back to surgery, right? And 6 months later, if you asked me, where did you get hurt? I couldn't even tell you where I got hurt. Right? And so to that surgeon, he heard it, he was ready to take me in for surgery. And so my takeaway for me moving forward is, when I'm in pain, I want to first go talk to somebody who can understand non-surgical interventions. And when that person says, hey, look, there's nothing more we can do unless those red flags show up and I suggest you go to surgery, then go to a surgeon. Because otherwise, sometimes it can be too quick to recommend surgery.
So,
Yeah, anything you wanted to say to that, Kashinath?
Uh, so, what happens is nowadays, fortunately, as I said, the science is so evolved that this difference is because of now the in the medical science there is 3 plus 3 is not 6. We always say 3 plus 3 is anything between 2 to 10. So sometimes this happens, but yes, I am also of opinion if there are no red flags, then the conservative treatment is the best, or the interventional, like the whatever we say, the block. These are the best options available. Now, if not, then yes, the surgery remains the option.
Got it. Got it. I know we're running out of time and there are questions, but I want to ask one question before we move to the audience question, and that is, opioids. They, in the US at least, they were prescribed a little too freely. And there were some, some reasons for it, obviously, that were not the right reasons. And so it caused a big crisis. However, there are places and times when they are the right thing to do. Right? How do you think about when you want to give opioids and how you manage, the fear of addiction that some people have?
So, there is one wonderful saying about the opioid is, if it is used for a correct purpose at a correct dose, it does not causes addiction. And at least in India, and at least at our setup, the correct purpose is the cancer pain. So this is the commonest prescription from our side to the cancer patients. Of course, if they don't develop the side effects, because opioid has its own sedation and the constipation, and if the patient is elderly, then that becomes a little challenging. But if it is used correctly for the correct purpose, then there is no risk of addiction. And yes, you rightly pointed out that in USA there is a lot of crisis was going on, and so in India and at our clinic we are avoiding it to use for the non-cancerous patients. Rather than there, in spite of using the opioids, we are trying all other modalities. That's what now I just enumerated. We go for those first, and then fortunately we have to rarely use the opioid in non-cancer patients. So the best way to go ahead about it, for the cancer patients, yes, opioid is one of the part. If the patient tolerates, we must use the opioids. But in non-cancerous patients, should not use the opioid unless all other options are exhausted.
Got it. Got it. Very helpful. So let me just go to audience questions. Kashinath. Savita said, my almost 80-year-old dad who had chikungunya still has pain a year on, though he has come a long way. However, the pain definitely limits him and he's nowhere close to being able to do the same things that he used to do right before the infection. Is there a solution to this?
Yeah. So is the pain in the one joint or multiple joint? Because post-viral arthralgias or post-viral myalgias are very common these days. And we had seen, especially in chikungunya, the pain stays there for years, and usually it is polyarthralgia. That means usually it is into the multiple joints, where we can use the drug disease-modifying agents, or we can do the dry needling of different joints. And if some particular one or two joints are more painful, we can go and do the blocks for that joints.
Got it. Got it. And by the way, Savita, who asked the question, I think she got the answer she wanted. So thank you. Uh, Sunya said, thank you so much for your wonderful explanations of the physiology and science of pain. So many things make so much more sense now. You are an amazing teacher. Do you have any advice on treating chronic pain due to menopause-related frozen shoulder?
Yes. So frozen shoulder wonderfully responds to two treatments. One is simple dry needling, or second is something called as hydrodissection. What we do, what is frozen shoulder is? Shoulder is frozen, as the name suggests. The movements are painful and restricted. Very much common in either diabetes or thyroid patient, or it can be occur in otherwise normal patient also. But this is an common. Now, what happens is under ultrasound we put a 40, 20, 30, 40 ml of dextrose into the joint. And what dextrose does is it breaks the adhesions. Frozen shoulder is called as adhesive capsulitis. It breaks the adhesions, and almost the success rate is 90-95%. So it's called as hydrodissection. Uh, we prefer to do it under ultrasound guidance, live ultrasound guidance, and it has got a very wonderful, results. So I'll suggest you can visit any pain specialist around you, and if you're not from the Pune city, this is one of the wonderful technique.
Kashinath, is this a very painful
No,
shot?
no, no. No, 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 not at all. So, okay, two things. The most of the interventions are not very much painful. It is just like an injection. We do it under local anesthesia. Technically, it sounds very much complicated, like we put the fluid and all that things, but it's not painful. It's done under local anesthesia, and usually you can start almost all the activities right maybe after an hour or 2 hour or maximum on the second day.
Wow. Wow.
Except for this spinal cord stimulator and intrathecal pumps, but those are also rare because the cost is very high. So all the things are very simple to do, simple to receive, simple to give. Technology is that's the different part.
Right, right. I think Sudhne just said, thank you so much. It gives me so much hope. Savita said, it's amazing how you've explained everything in such a simple way. Very interesting. Totally enjoyed the session. Saili's question is, does yoga help in pain management?
Yes, definitely. Yoga helps for the prevention of the pain. Yoga helps in curing the current pain. Yoga helps after the pain has been cured as a rehabilitation to avoid the recurrence of the pain. So yoga helps. But if you are having a pain and if yoga is increasing the pain, then this is something, first get it treated and then do the yoga.
Yeah. And I also imagine that just like pain management, even yoga, when you're doing it in the presence of pain, you need to have the right yoga instructor
Yes,
who
right.
knows how to modify the poses for that to deal with the pain and get to use it for true management.
True. Same stands for physiotherapy. Sometimes pain after physiotherapy, pain increases or pain restricts the exercises and yoga. So correct way of doing is very important. And as you rightly pointed out, the perfect person, perfect instructor is the must in all these things.
Yeah. Sujata had a question. Any advice for post-herpetic neuralgia?
Yeah. Post-herpetic neuralgia, as I think this was the first example we gave. Even if the herpes is gone, there is a post-herpetic neuralgia. Madam, there are different treatments that can be done, right from applying only local anesthetic jelly to the botulinum toxin injection, dry needling, or doing the radio frequency ablation of that nerve where the herpetic neuralgia is there. So usually herpetic neuralgia affects the segments of the nerves or nerve segments. We have to do the radio frequency ablation. If the medication is not working, then these are the treatments. And in post-herpetic neuralgia, don't delay the treatment because the success rate is inversely proportional to the duration of the pain. In few patients, it could be self-limiting. That means even if you don't do anything, it goes down. But yes, in few patients, if it is not responding, please get it done. Yeah. And there are ways available.
The person asking the question, Sujata, just recently dealt with shingles. And so we all know how painful shingles can be. And so timing of this advice is perfect.
Yeah, it's very painful.
I know we are out of time. But there is so much, not only that we learned, Kashinath, today from you, but also there are so many other topics that I wanted to talk about. But if you are open to it, we will again in the future set up a session. We don't want to take up too much of your time, but I think it serves exactly what I was hoping for it to serve, which is increase our awareness of possibilities. I know I'm getting so many messages on the side right now about people saying, "Hey, this has given me a lot of hope. I'm going to, go figure out this and at least ask the right questions." And if we have people in Pune who want to get to you, we'll make sure to put your contact information in the show notes that we will send out with the
Thank
session.
you.
But thank
Thank
you again so much, Kashinath.
Thank
You
you.
serve a great purpose to society, and we appreciate it.
Thank you. Thank you, Nikhil. And pain is never in the head. If somebody tells you कि your pain is in the head, 99.99% that is not true. Science is not able to diagnose. That is the correct thing.
Yeah, yeah. That is a great way to end the session. I hope you've been seeing all the love that people are pouring
Yes, yes.
for you
Thank you
for the
very much.
session.
And thank you, Nikhil. I am really grateful to you for having such a wonderful community and such a wonderful communication.
Thank you, Kashinath. Bye
Okay.
bye.
Yes. Bye bye.
Bye,
Thank you.
everybody.
Yes.